talking about skin tears, the obvious progression is talking about pressure injuries or pressure ulcers, however you allude to them. So the first thing that we need to get out of the way is why somebody calls them injuries while other people call it ulcerations. The debate was that, for example, a stage 1 pressure injury is not an open wound, therefore we cannot call it an ulcer. However, the debate is about the terminology. It will not affect anything about the prevention and management of these wounds. The first thing that we need to remember and understand, those patient-centered concerns, the health-related quality of life. These type of wounds can be quite painful. They cause anxiousness in our patients, and it is really important to understand that many patients will be at risk of pressure injuries. We are not just talking about very sick patients in the critical care unit. If you think, for example, of patients who had spinal cord injuries and they're now wheelchair bound, even though they can be young, many of them will suffer from these unfortunate woundings. So what causes pressure injuries? The cause of pressure injuries is the occlusion of blood supply going to a part of the skin and underlying tissue, which will lead to cell death. That happens because of direct pressure and or shear. If I had to ask you if you ever had a pressure injury yourself, probably you would be thinking, no, definitely I haven't. But if I remind you the last time you bought a new pair of shoes and you ended up with a blister at the back of your foot, that is actually a stage 2 pressure injury. We're saying this because although everybody is at risk of pressure injury, this depends on the tissue tolerance that we mentioned previously. So this is why we need to do a risk assessment that we'll discuss in a few minutes, but making sure that everybody is categorized, make sure that we put in the prevention as needed. So how much pressure is needed? Do we need a lot of pressure to create a pressure injury? To ascertain this, we need to look at the amount of pressure that is in the circulatory system. So if we look at the capillaries, which joins the arterioles and the venules, the pressure in there is approximately 32 millimeters of mercury, while at the venous end, it actually drops down to 10 millimeters of mercury. So it has been calculated that anything above 17 millimeters of mercury of pressure will occlude the circulation. And remember that 17 millimeters of mercury is really very gentle pressure. What happens is that when we have an external force pressing on the skin, it will put the pressure over 17 millimeters of mercury, which will occlude those capillaries. Previously, we used to say that for a pressure injury can occur only over a bony prominence. With the new publications that we have and with the new evidences, we know that yes, the bony prominences or pressure points are still very much the most vulnerable parts of the body to get a pressure injury. However, a pressure injury can happen everywhere. This is why nowadays we also talk about device-related pressure injuries, where, for example, during the COVID times, the most common type of reported pressure injuries were device-related pressure injuries in healthcare professionals that were working with protective equipment for long hours. Apart from pressure, we can have also shear, for example, where the patient is sliding in the bed, the circulations, the capillaries will angulate and will even make the matters even worse. How long must we wait for a pressure injury to occur? So the initial hyperemia actually appears only after 30 minutes of unrelieved pressure. You might have seen this in yourself when you wake up suddenly, you look at your face and your face looks like Google Maps. That's because you haven't moved your face for quite a few minutes, which fortunately enough resolves after about 1 hour. This is why when we do the statistical analysis of data in our facilities, we should not include stage 1 pressure injuries because they usually resolve quite quickly if we relieve the pressure. If we apply pressure which is unrelieved from 2 to 6 hours, we are sure that this will cause ischemia that can still be reversed but can take up to 36 hours to resolve. And this is where we get the notion that our patients should be changed in their position every 2 to 4 hours. If the unrelieved pressure continues for 6 hours or more, then microvasculature collapse occurs, thrombosis occurs, and a pressure injury will definitely ensue. If we had to look at definitions by the advisory panels from Europe, from America, and Asia, they agree together that the definition should be a localized damage which occurs on the skin and or underlying tissue, usually, but not always, over a bony prominence, which can be related to a medical or other device. This can be presented as intact skin or an open ulcer that is more often than not quite painful. The main or the actual resultant problems that cause pressure injuries are pressure and shear. However, other things like microclimate, like nutrition, etc., are events that will make the patient more prone for pressure injuries. The other discussion that we can have is, are all pressure injuries preventable or not? Statistics vary. They can vary anywhere from around 50% to over 90%. However, we need to make sure that we try to prevent them as much as possible. What we need to do is evaluate the patient's condition and define a plan of care according to their risk. We monitor and evaluate the impact of our interventions if they are reaching their desired effect, and revised whenever appropriate. If we have done all this and the pressure injury still occurs, then we can call it an unavoidable pressure injury. However, we should not be complacent. We should still make sure that we are preventing the care. We still need to make sure that we are giving all the information to their patients and their relatives, because sometimes the patients and or their relatives don't want to turn the individual because it's painful or whatever. So therefore it's very, very important that we make them understand why turning the patient is of great importance. In the past few years, we have been talking pressure injuries in relations to quality indicators. In many countries nowadays, facilities have to make public the statistics of pressure injuries. We have also some countries where if a facility has a big rate of pressure injuries and there is no remedial effect in this, they can actually lose their license or also lose the support that they get from the governments. Why do we count pressure injuries? We do that because we need to examine what we are doing, if it is giving us the best effects. We look at three things, like how things are changing, are they getting better or worse, and this statistics in relation to what we are doing in the care of our patients. So how do we calculate and look at numbers when we are auditing pressure injuries? There are two main ways. The first one is prevalence. So with prevalence, we go out on the units on a specific time and the specific dates, examine all the patients, and put the statistics of how many patients have got pressure injuries. Importantly, note that we are talking about patients with pressure injuries, not amount of wounds. Then we do a simple division and we get with the percentage of pressure injuries. So prevalence will include whatever we have on the day, whether they were hospital acquired or community acquired. On the other hand, incidence data will include only hospital acquired number of pressure injuries or patients with pressure injuries, which are reported immediately but included in the data analysis that we do, for example, every quarter. Why is that important? The importance of it, as we said, is making an analysis if our statistics are getting worse or are they getting better, and is this in relation to all the preventive methods that we implemented in the patient's care. However, when it comes to incidents, the important part of incident reporting is to ascertain the root cause analysis, understanding exactly why it happened, studying what led to the incidence of pressure injury, making sure that we learn from that experience, making sure that it doesn't happen again because of modifiable risk factors that can be changed according to what we have learned. As with skin tears and with all the other wounds, there is a staging system in place, and what we need to do in order to stage a pressure injury, first of all, obviously do a full head-to-toe skin assessment to see where there are any injuries or not. If we do find a pressure injury, we have to clean it before we stage it, because we have to look at the deepest anatomical location, and remember that we stage according to the layers of the skin, not according to how deep it is in millimeters. Because, for example, for a stage 4 pressure injury to appear on the patient's nose bridge, it's only a few millimeters deep. If it appears on the patient's, for example, sacral area, it could be quite deep. So always look at the layers of the skin rather than how deep in millimeters. So let's go briefly through the stages of pressure injury. A stage 1 pressure injury is described as non-blanchable erythema. So when you press your skin and you leave it, you see that the part where you pressed becomes paler. If you have erythema of a stage 1, when you press and leave it, it will still remain red or darker in nature. A stage 2 pressure injury is where now we have partial thickness skin loss or a blister full with clear fluids. Stage 3 pressure injuries are full thickness skin loss. You can have undermining, you can have tunneling, you can have slough and eschar as well there. However, you still can see the deepest anatomical location, and epipole can also be there. Stage 4 pressure injury is almost the same as a stage 3. However, with a stage 4, now we have full tissue loss, and we can see the deepest anatomical location, bone, tendon, muscle, cartilage, etc. If we have a stage 3 or a stage 4 which has slough or eschar in it, where we cannot see the deepest anatomical location, then we document it as unstageable. Once the debridement and or the sloughing is done, then we stage it accordingly. Deep tissue pressure injuries present themselves as hematomas or else blisters filled with dark fluid because there is bleeding underneath. These deep tissue pressure injuries, if you remove the pressure as soon as possible, they can resolve. However, if they don't get offloaded, then they can easily become a stage 3 or a stage 4 injury within a very short time. Another description of a pressure injury is a mucosal membrane pressure injuries, which occur inside the mouth of the patient and the nostrils. This is more often than not caused by devices such as ET tubes and nasal prongs. Because the mucosa doesn't have layers like the skin, with mucosal pressure injuries, we do not stage them. Device-related pressure injuries can be any stage of these that we talked about previously, but are caused with an external device, which could be either a medical device or any other thing which presses on the skin. It mimics the outline of what has caused pressure, and it can be caused by anything like creases in the linen or breadcrumbs and crumbs in the bed of the patient, sometimes even a charging cable for a mobile phone that the patient goes on. But remember, the most common is medical devices, leaving things which cause pressure on the patient's skin. So when you are using any device which is attached to the patient, make sure that we take care that this device is not causing pressure and will not cause a pressure injury later on. Another thing that we can sometimes forget is a group of patients who can be at high risk of pressure injuries. And here we're talking about patients who go to operating rooms for long procedures. Remember that these patients are already many times compromised before they go to the OR. They are going to lie on a very hard surface for a long time, and we definitely cannot turn the position of the patient during an operation. However, there are things that we can do. Nowadays, you can find overlays that are specific for the operating room tables, making sure that the heels of the patients are always elevated, using things like hyperoxygenated oils that will increase the transcutaneous oxygen of the patients. But most importantly is when the patient is transferred out to the recovery room area, the recovery nurse needs to make a proper head-to-toe skin assessment to ascertain if there has been any injury. If there is any injury, we need to offload it immediately, and once the patient is handed over to the unit, then a handover should include that a pressure injury has occurred to make sure that we provide offloading to that area. Also importantly, again, the confusion about etiologies, because sometimes pressure injuries are confused with skin tears, sometimes even with moisture-associated skin dermatitis. Pressure injuries have a history of pressure and/or shear, as we said previously. Most often than not will happen on a bony prominence, while skin tears, as we said in the previous session, usually appear on the arms and the dorsal of our patients. And while with MASD we have moisture which is causing the injury, one of the biggest differentiating factor is that the erythema in MASD, once you press it, it actually blanches, and it usually happens between folds. Another misconception about pressure injuries is reverse staging. For example, you can find in documentation that a stage 4 pressure injury is now healing and has become a stage 3. This is incorrect because the wound is being filled up by scar tissue which doesn't have layers like the skin. So what we are saying here is a stage 4, even when it's healed, we always refer it to a stage 4 that is healing. The best way how to document these type of injuries is by means of using a document called the push tool, which you will find in your activity book, which gives us a graph of how the wound is progressing or unfortunately regressing. The next step that we need to talk about, obviously, is the risk assessment. And when we're talking about risk assessment, one of the most popular grading system that we have is the Braden score, which was created by Braden and Bergstrom in the 1980s, in 1984 actually, that includes 6 ulcer risk prevention assessments, where we go from sensory perception all the way down to activity of the patient. We give a score to each of these subscales, and according to this scale, it will give us the risk of our patient. The lower the score, the more at risk our patient is. Importantly, we do a risk assessment not to complete something for our KPIs, but that risk assessment will give us a nursing care plan how to prevent pressure injuries in those patients. If we're using these type of risk assessment tools, it should be done within 2 hours of admission of all patients to acute facilities, repeated on every shift change, and then also if the condition of the patient changes. If you are using the Braden scales, please make note that the Braden scale is for patients who are 8 years and above. If you have patients between 3 weeks and 8 years, there is another tool called the Braden Q, and then in patients who are newborn up to 3 weeks, you need to use the neonatal infant Braden Q. There are other types of risk assessment tools. Probably the 2 most commonly used also are the Waterloo's and the Norton, where we have publications which have said that all 3 are very good, but in one of the publications especially it suggested that the Braden is more sensitive to changes. Remember again that the risk assessment is being done, because according to the score you are getting, you should have in your policy a list of interventions that we need to do. The other unfortunate thing for our patients is that, unfortunately, some clinicians will not know how to position our patients properly. We have, I'm sure that you are aware of the international patient safety goals, and one of the things that you find there is that a patient that has a pressure injury on the trochanter area or the heel, that should also be eliminated as a never event, something that should never happen. Why? Because when we position the patient, we should position the patient at a 30-degree turn and a 30-degree head tilt. Why do we do this? Because when we turn the patient 30 degrees, only half of the body is touching the mattress and the other half is not touching it. So then after 2 to 4 hours, you change the position of the patient and you alleviate the other side. Heels of the patient should always be elevated and should never touch the mattress. If we have to raise the head, ideally it should be 30 degrees or less. We know that there are certain conditions which will not allow us to do these types of turnings and the head tilt. However, we still need to do as much as possible prevention strategies not to get pressure injuries on these patients. Another class of patients that I already mentioned who are very much at risk of pressure injuries are patients who are chair-bound. These patients who are in wheelchairs and who are sitting down for very, very long hours are more at risk because pressure is concentrated on smaller areas, and therefore one of the first things that we need to teach these patients is to make sure that they lift and change their position every 15 minutes. If they can't do it themselves, we have to do it for them at least every hour, making sure that the equipment fits the patient properly, and we can also use cushions which are specifically designed to relieve pressure in these patients. Like we have the air mattresses and the eggshell mattresses and honeycomb mattresses for the bed, we have the same type of cushions available for wheelchairs. Education of these patients are very important because these patients don't get pressure injuries just on their sacral regions. Their heel and the back area where they have the calf muscle are also at high risk. So apart from teaching them how to prevent their pressure injuries, it is also important to teach them and their carers where to look to find if pressure injuries are happening, and if, for example, a stage 1 pressure injury is already there, to make sure that the pressure is removed. One of the ways how to prevent and manage pressure injuries is by means of implementing a nursing care bundle. Some years back we had the skin bundle that came out of the US and then was amended in the UK to make it S skin. So what is this bundle? The first S is alluding to the surface. What type of surface do our patients have on their bed according to the risk that we got from the scoring using the Braden or other risk assessment tools. The second S alludes to skin inspection, where we have to do a head-to-toe skin inspection for our patients to make sure that there are no areas which have become erythemas, or else understand that they are prone for pressure injuries and making sure that these are not occurring. The K is for keep your patients moving, which means that you do turn your patients even at night, although at night it's ideally to keep it as long as possible, usually around 4 hours, but it also is telling us that we need to ambulate the patients as quickly as possible. I is for incontinence management, moisture management, making sure that the skin of our patients is kept clean at all time. Try to avoid using diapers as much as possible. Use of barrier creams, although they do not prevent pressure injuries, but by means of using a barrier cream, it will keep the skin healthier, therefore less at risk of pressure injuries. N is for nutrition and hydration, making sure that all our patients who are at risk of pressure injuries get seen by a clinical nutritionist, making sure that we are offering these patients at certain times water to drink to keep hydrated. Remember that certain other strategies, for example the hourly visiting of our patients, is also important to make sure that we offer to them to go to the bathroom to help them keep their continence in check as much as possible, making sure that the environment is free from any problems like avoiding falls, but also giving them a glass of water every hour will help to keep their skin moisturized. Also, please remember that old contraptions like donuts, synthetic sheepskin and gloves filled with water do not actually prevent pressure injuries. They put our patients even more at risk. What prevents pressure injuries is doing a proper risk assessment, positioning them properly at a 30 degrees and following the suggestions of the S-skin pump.